Today on Future of Everything, a special episode devoted to COVID-19 pandemic. We're talking today about how one hospital in Silicon Valley is using data and data science to help drive their response to this COVID-19 crisis. We're using internet, and so I apologize in advance for a lower quality of sound. I hope it still works for you. Now, Stanford Hospital sits in the middle of Silicon Valley in Santa Clara County, one of the hardest hit counties in California for the COVID-19 pandemic. It's a brand new hospital, opened in 2019, late in 2019, beautiful, and no one expected that one of its first challenges would be this pandemic. It now faces an entirely different set of challenges. It's part of Stanford University, and Stanford University has a rich history of computer science and medicine coming together in research. But now the research becomes very pertinent. Professor Nigam Shah is a professor of medicine and biomedical informatics and is helping to organize a remarkable effort to respond to this crisis with data. Nigam, thanks for being here. A month or two ago, you were a professor, you had your teaching duties, you had your research in electronic medical records and the ways they can be leveraged in healthcare. How did your life change, and how did you become involved in this real on-the-ground effort, which we'll be discussing in a few minutes?
Thank you, Russ. I wish those days were back. Teaching, professorship, all good. So what happened is that, one of the senior leadership in the dean's office, we had a call one day, I think about 10 days ago or something, saying that what could we do with data that can help our health system remain even a few steps ahead of this situation. And we brainstormed a list of 5-10 things worth doing, mostly boiling down to counting things, because we're one of the largest testing facilities in the area. And the number of tests coming out positive, the number of people we're testing, the number of people that we're admitting, the number of people that need an ICU. So we just started counting simple things, like 3 or 4 things. That's how it started.
Yes. Now, this was a call from the dean, knowing that this tsunami was coming. Were there any hesitations, or was it obvious what you had to do?
I would say no hesitations. I mean, we're all in this together. The world is a different place, which, we're talking to each other on Zoom instead of being in a studio.
Yes.
So at this point, I don't have any hesitation about dropping things we were doing and making sure that as a community, as a society, if there are skills we can have as data scientists that help the situation, of course, why not?
Great. So you said you started counting things. I could imagine what they might be, but I'd love to hear what were the priority things to count. And even to this day now, almost 2 weeks in, what are we good at counting and what's a problem?
Mm-hmm. Excellent question. So you might know that in the news and everywhere, people are reporting confirmed cases. And that's sort of the base thing people start with. And in order to have an understanding of the epidemic, we need to know how many people actually have the disease. We need to understand transmission, incubation times, like infection to getting symptoms, things like that. We don't know much of that yet, or not as accurately. So what happens is that you have limited testing, you've tested 100 people, a few come positive. And from that, you're making all sorts of assumptions to derive what is the true number of infected people. And from that, you base your policy decision and so on. And these uncertainties keep compounding one after the other. And at the end, your estimates have so wide uncertainty that you can't make much sense of it.
Yes.
So we said from a health system perspective, we're not in the business of modeling the epidemic. Our duty is that when people around us are sick, we're there for them.
Yes.
So what matters is knowing how many people will need a bed tomorrow, the week after, and the week after. Because if I know that, then we can cancel scheduled surgeries, we can turn ORs into ICUs, we can start cohorting patients, we can request anesthesiologists to help with critical care. All sorts of these machinations inside of the health system can be done if we know reasonably accurately what's coming tomorrow.
Yeah, so there are
And
these people who would be in charge, for example, of putting up tents or recommissioning new buildings, and they need to know how many beds, and you can't do it at the last minute because there's a latency or a lead
exactly,
time for every one of these decisions. Great. So
exactly. It
how did
takes
you
a while
approach
to
this
move physical
challenge?
objects in the world.
Right, right. So how did you approach this challenge of getting them numbers that were reasonable?
Yeah, so we first started doing the usual thing, like, let's look at infected cases, and then from that, make a bunch of assumptions and back calculate, get an estimated prevalence. And then based on the estimated prevalence, assume that 80% of the people will be fine. And, some people need a hospital bed, and arrive at that indirectly.
Yes.
But then we learned that the Santa Clara County is at the forefront of even reporting number of hospitalized cases. So we started interacting with the county officials. And then after having 10, 15 days of data on the number of hospitalizations,
Yes.
we can then just fit an equation to that and project the next day or the next 5 days. It's not fancy. It's simple arithmetic and multiplication. But from a response planning perspective, it's way more accurate than having a fancy simulation.
Now, when you make these projections, are you considering that Stanford Hospital is responsible for a certain geographical area? Do you imagine the possibility that there'll be a flood of new people from outside, or a flood of people out of Santa Clara to other places? How do you manage that? Or are you assuming that because of the shelter-in-place orders, that these things are kind of fixed and there's a known kind of group population of people that Stanford is responsible for?
So for the response planning efforts, we're kind of assuming a stable population. But as part of the larger data science effort that I described recently, there are many other faculty who are modeling population migration, or modeling changes in the infection rates, changes in the transmission because of shelter in place, closing schools, and so on. And their models are giving much richer output that is being used by our county officials, and to some extent even our state officials, to inform their decision making.
Great, and that's where I wanted to get to next, which is, okay, so you now have this counting, kind of a census of patients. You also referred to the fact that you're going to be doing some modeling and projection out into the future. Can you share some of the findings? I know that all of this is very preliminary and this is all best effort, but are there any surprising things when you do this exercise? Are there any things that you've learned that were like head scratchers, or, oh my goodness, this is not what we were expecting?
So a couple of things. I mean, the first was that how reliant are we on testing availability? And that the fact that we don't have the luxury to just go out in the community and randomly sample 10,000 people, I'd not anticipated that to be such a major bottleneck in back calculating the estimated prevalence. And as a result, that testing is mostly a healthcare activity right now and not a public health activity.
Yes.
That has resulted in much wider uncertainties in the estimated prevalence that we're able to calculate.
This is the future of everything. I'm Russ Altman. I'm speaking with Dr. Nigam Shah about how one hospital in a hot zone for COVID is trying to use data to inform its activities. I'm sorry, so you were saying that there were some other surprises?
Yeah,
or lessons learned?
Yeah, so the other surprise was that it's very hard for other hospitals and other county officials to spin up the kind of response that a hospital that has a university attached to it is able to.
Right.
But things that we would have assumed that our students do or are kind of easy, quote unquote, turns out that they're immensely helpful for others. And so we ended up going from Excel spreadsheets that just we use to then partnering with a lot of people, mostly led by David Schenker and Kevin Schulman, to then put up a web-based tool that others can use. And there's multiple other web-based tools, but the main different thing we did is that we pre-calculated and include the county age distributions and the county populations and the known bed capacity of those counties and the hospitals in those counties, which then reduces the burden for others to make these kinds of calculations for their own plan.
Okay, so this sounds very exciting. So if I understood you, you took the local lessons about how to do this calculation from the Stanford County, the county Santa Clara where Stanford resides, and then you built a tool that a hospital in any county, is this statewide or nationwide?
It's actually nationwide. And so the credit here goes to people working out of SURF,
Yes.
and for SURF, and people from the pediatric hospital, electrical engineering, like a group of 15 faculty and students across multiple disciplines. And we just launched it outside of a password protected site yesterday.
So now tell me how a hospital administrator in County X in State Y, they would go to your site, what would be the question they would have, and what would be the answer that they get?
They would need to answer two questions. The first thing they need to answer is the number of hospitalizations in their county as of today.
Okay.
And if they've been calculating or keeping track of the number of hospitalizations over the past whatever duration, a week or two, then they can also enter the doubling time.
Doubling time, could you define that for people who are not?
Yeah, doubling time is basically the amount of time it takes for the number of hospital beds you need to increase twice or twofold.
So you go from 10 to 20.
Yeah, exactly. And then if you have about a week or two of data, you can estimate that number. And if you can't, there's a default which we've estimated from lots of national data. So you could go in with just one number. How many beds are occupied in your county today?
Yes.
We will pull the county census information from public sources and then make you a plot of what would life look like in terms of the bed capacity needs in your county, given the input you provided and say the 5 to 6 day doubling time.
Now that's great, and that would be useful, and I'm sure that would lead them to get results that would be startling, because doubling is a bad thing, and it might get several doublings. But now we have these interventions. Governors around the country have said shelter in place. Everybody in the world has heard about bending the curve down. Yeah. Is your tool and is your research able to model the potential effects of success in the shelter-in-place strategies?
To some extent, yes. So the hard part there is coming up with a good guess as to if people shelter in place, what will that do to this doubling time?
Right.
If you can input that, yes, we can draw the curve of what would life be like if the doubling time itself doubled.
Yes. Yes. So do you have any preliminary data? And I want to talk about this very carefully because I don't want to get people overly optimistic or pessimistic, because I don't know when listeners are listening to this, but right now we don't know if the shelter in place is being effective in many places in the United States. Do we have any, well, let's take the case of your hospital. Are we beginning to see any effect from the shelter in place for as long as it's been enforced within the Santa Clara area?
So it's too early to make a definitive call. And to anyone listening to this and you're out of context, the thing to remember is that whenever you intervene with like a shelter in place order, given the lag between being infected and getting a symptom, which could range from anywhere from 3 to 14 days,
yes,
there's a lag between putting a measure in place and seeing its effect on something like a hospitalization rate. So we can't make the call definitively, but what we are saying is that the rate at which hospitalizations were rising is slowing.
Okay, so that's good news. And
it's
we're not.
So I would say it's not bad news yet.
Right. Good. Not bad news yet. Very good. So I want to just step back a minute. You made a reference, and I don't want to lose this thread, to the fact that people came together in an interdisciplinary way. Perhaps even they didn't even know each other 3 weeks ago. So can you paint a picture for me about how the academics researchers are responding to this challenge? We've all heard in the news about the terrible situation that some healthcare providers are enduring, and their really heroic efforts to take care of patients. And so putting that aside, because that really is remarkable, tell me about the researchers and those who are not in the front lines and the experiences you've had with them coming together.
Mm-hmm. So, I mean, as you know, Stanford put in place a work from home recommendation, and then with the county enforcing the shelter in place, I mean, most of us with research labs are essentially sent home.
Right.
And these are smart people who know how to do good science, and they can't work in their labs anymore. And the amount of individuals who wanted to help with no expectation of anything in return, it was just astounding. It's absolutely astounding. It's both refreshing and humanizing at the same time.
Yes.
That such smart, incredibly high IQ people, when the time comes, will drop everything and come to help out.
How do you manage the tsunami of interest that comes? Because yes, they're talented. Yes, they have great ideas, but somebody has to figure out how to make all those oars row in the same direction. Do we have preliminary learnings about how to do that?
That's an excellent question. So I ended up in the situation of having to be that person. And about 4 days, I was, my hair standing up and completely wiped out, because the amount of cognitive load that is needed to process, 50
Right.
people, 60 people, all with good intentions, but needing support and coaching to connect with each other is just astounding.
So how did you do it? Give us some pearls of wisdom about how you manage 50 enthusiastic helper elves.
So the thing we figured out is that you train 3 of them on the condition that they have to train another 3.
Pyramid.
Exactly. You have to have this beneficial Ponzi scheme, so to speak.
Yes.
That we will let you in and explain the data to you if you explain them to 3 other people.
That's great. How do you manage the tension between there's something I know we need, could somebody please do this, versus anybody who has a good idea should have a little bit of time to play with it in case it leads to something great. So I would call that perhaps top-down management versus bottom-up. Have you found a way to balance that?
We just started an experiment. So about 3 days in, when I was pulling 14-hour days, I requested a professional project manager from the dean's office. And then once she joined, Jessica Kennedy is her name, what we ended up doing is now we have sort of a self-sign-up page. So we have 3 things going. We have a place where clinicians can submit a question saying, if you answer this from data, it would be a huge asset or huge help to me. And then we have researchers listing their skills and the level of freedom they expect to be able to perform at in terms of solving these questions.
I'm good at working with others. I do my best work alone, etc.
And their skills, R, Python, SQL, whatever. And then we periodically, twice a day, go through that, literally doing keyword matches and saying, this person, this question, they understand this, do an email intro, and then hope for the best.
Fantastic. Well, that is actually very inspiring. This is The Future of Everything. I'm Russ Altman. More with Dr. Nigam Shah about how one hospital in Silicon Valley is trying to use data science to address the pandemic, next on Sirius XM. Welcome back to The Future of Everything. I'm Russ Altman. I'm speaking with Professor Nigam Shah about how one hospital in Silicon Valley is trying to use data science to combat this COVID-19 epidemic. So Nigam, in the last section, you gave me a really nice detailed description of how you've helped this hospital understand the burden of disease, what they can expect in terms of beds and sick patients. But I know it's a broader effort that you're involved in, and that actually there are a number of data science needs associated with this epidemic that you're working on with your colleagues. So can you tell me what those are?
Absolutely. So, I see sort of 3 categories of data needs. The first one, and let's call it the research data needs, is us understanding the virus, the pathogen, its sequence, how it evolves, what's the protein structure it binds to, what drugs might affect it, doing prospective studies, and so on.
So this is science.
The science. It's called the science of this. The second category is understanding the epidemic dynamics, the time from infection to symptoms, how many people does one person infect, what are the migration patterns, how does weather affect the distribution, and so on. So let's just call it epidemic modeling.
Epidemic modeling, and that's different from the basic science. This is more at the population level and clinical level.
Correct. And the basic science informs population science, and the population science gives us the hypotheses to pursue in basic science. And then the third is kind of the operational, on the ground how many beds do I need tomorrow? How many doctors should I have on staff? Given my usage rates of personal protective equipment, how much do I need to order and when? And so there are three related efforts, and of course, they all inform each other. If the epidemic simulation says you're going to have 10,000 cases in 4 months, that does inform your planning.
Yes.
It just doesn't inform your tomorrow's planning, it informs your long-range planning.
Yes, and I would also guess that as we were talking about in the first segment, as a manager, you're able then to take participants and try to match them to which of these three areas their skills are most applicable.
Absolutely, and have collaborations between them. So for example, you can have somebody who's studying the biology of this partner up with somebody who is doing a population survey so that they can leverage the population survey to get the right samples in place.
Yes, so I would expect that maybe you have examples already of those groups kind of finding each other and doing collaborative work, or is it still too early?
There's already a couple of groups that have formed, so definitely existential proof that stuff like this can happen, particularly around testing and screening the population to see that what is the true prevalence of this condition.
So that would be the interaction between the second and third tier, if I'm getting it right. So we learn about the rate of testing and the positivity, and that will inform the policymakers who are on the ground making decisions.
So that plus, when we survey people for their symptoms, we can then leverage their responses to decide to whom should we send a home testing kit in order to get a population estimate of the prevalence. So interactions between all three buckets, two-way interactions.
Yes, and I'm going to cut because I forgot what my next question is. Do you remember what the next topic was?
I think it was something like, what would you like to say to the public?
Well, that's at the very end. No, we had, see, now I'm confused about what we did in the first section and the second session, but okay, I'm just going to go for, let me just pause for a second. This will all be taken out. What was my next question? We talked about the examples of the interactions, the data science.
So you had asked about how the marathon and sprint thing.
Yes, yes. Okay, good. This is the future of everything. I'm Russ Altman. I'm speaking with Nigam Shah about how one hospital is using data science to respond to the effort. So Nigam, this is very exciting. You just described three separate areas, all of which there's data that can be used to help understand and battle the epidemic. How do you manage people in this situation? I'm sure you have a lot of excitement and a lot of excited colleagues. But the timescales of them making different discoveries might be very different. Like clinical trials take a long time. The rate of testing tomorrow is very measurable. How do you manage the morale and measure progress in these efforts?
That's an excellent question, Russ. I mean, there's multiple levels to think about this. One is we have 50, 60 highly creative individuals who are willing to donate their time and effort in order to fight this common problem that we're in. And imagine like it's a sprint, and on an adrenaline rush, we can probably do it and sustain it for maybe 3 weeks, maybe a month. And we have to think about how are we going to make this sustainable?
Yes.
And then when I get to sustainability, we have to think about it at two levels. We're not just Stanford and this group of 60 humans, but if this kind of a pandemic thing happens often, science is advanced enough that given a pathogen, we can find a vaccine, but it takes about 12 months. And then as an institution, as society, how do we sustain our normal functioning, much like we would do for other calamities that we prepare for, like a tornado, and we have a fire, and we have a fire drill, and a tornado, we have a tornado drill. Can we flip between working distributed and working communally?
Yes.
On a fast basis.
So yes, so I would gather that right now people are working on adrenaline. They're acting like it's a sprint. Your worry as a manager of this effort is that we need to retain some of that energy, because part of this pandemic will be a long haul. like, yes, maybe in the next 2 months we'll see a peak and then a drop, but there's the possibility of a return next year. There's a possibility that it will transfer to the winter in South America. Do you see that infrastructure? What kinds of infrastructure do we need to put in place so that this isn't a sprint, an exhausting and totally paralyzing event every year?
Yeah. So, I mean, I don't have solutions yet. I'll share some of the ideas we're trying. That instead of one person deciding what projects are worth doing and matching people up, we've moved to this state where we have clinicians at the front line submitting questions to us. We have researchers describing their skills, and then every couple of hours or once a day, we sort of go through that, match people up,
yes,
and form a team. And while we sort of induct a team, the condition we do with them is to say, if we orient one person with the intricacies of the data and everything, that person has to pay it forward to 2 to 3 other people. So think of it as a beneficial Ponzi scheme,
yes,
where we can spread the knowledge, and it's not concentrated in just the 8 or 10 people who've been working with the data up front, but then we share with 12 people or 15 people, and they share with another 45. And so at least on the knowledge transmission side, we can scale.
And that could be put in place ahead of time with particular roles and responsibilities, maybe even mapped out, so that if the drill is called, if the alarm goes off, people know exactly who their team is, what the communication channels are. That's something that you had to make up on the fly, but could have been in place before.
Exactly. I mean, at Stanford, we have these phone trees that in case of an emergency, we're supposed to call these 3 other people and let them know. So we can have such a institutional plan that if something like this happens again, who's going to call who and what are they going to say? We can learn from the current experience.
This is The Future of Everything. I'm Russ Altman. I'm speaking with Professor Nigam Shah. I had 2 final questions. The first question is, how are you doing personally? You made a reference previously to long days, lots of work, a lot of adrenaline. This is also, I'm sure, personally stressful. How do you manage it? How are things for you?
So I'm trying to manage, and I'm thankful that for this effort now there's a professional project manager so that I don't have to do everything. And the strategy right now is to sort of let the teams come together, not focus on everything, make sure that the top 10 things that need to be done get done. If a few things get fall through the cracks, so be it. But it is important to preserve both mental and physical health in this situation.
Yes, and you have to give yourself a break. And if something does fall through the cracks, you'll recognize it, you'll pick it up the next day. The second question I want to ask is, what would you like to tell our listeners who are listening about this? It's extremely good to hear about these efforts to help the pandemic. What should they know, and what are the important points for them to take away?
So I would like to share 2 things with the public. The first one is this notion of an exponential growth, which is not very intuitive. And basically what that is something that grows by a certain fixed rate day over day. An epidemic that is growing by 15% day over day, even if you do something today, the end effect at 2 weeks out is still going to be 5 times, 6 times as worse as it is today, even if what you did worked perfectly.
Because it could have been 10 or 20 times worse.
Exactly.
So the fact that it's only 5 or 6 is a huge victory, even though it looks terrible compared to 2 weeks ago.
Exactly. And this continuous exponential growth, along with this lag between what you do and you see its effect, given that infection and symptoms have a lag, it's a weird cognitive dissonance where it seems like nothing you do works. And things are always getting worse. And it defies intuition. So the second thing I would say is trust your county health officials. Don't second guess based on intuition. It's not intuitive. Exponential trends are not normal for the human mind.
So we may be seeing interventions like shelter in place that are working, and do not judge them based on the superficial reality. Wait until somebody who knows what they're talking about gives you a read on whether it's okay or not.
Exactly. This is the time to trust the experts and not intuition.
Thank you for listening to The Future of Everything. I'm Russ Altman. If you missed any of this episode, listen anytime on demand with the SiriusXM app.